I'm Ian Tindall, Chair of the CALHN Research Ethics Committee. So my job is to run the committee which approves human research within CALHN. Pharmacist by profession, long career doing different things, involved in clinical trials, manufacturing, blinding, etc. for clinical trials, so long history in that. Took the job about 6 years ago when Queen Elizabeth amalgamated here and made CALHN. So yeah, fairly busy job, a lot of research in the area. So I just wanted to touch tonight on ethical conduct in medical research, and particularly with COVID, and those who have seen the invitation have seen me sitting in ICU there getting the Southern Hemisphere's first COVID vaccine, which turned out to be, wasn't very successful.
Southern Hemisphere's.
Yeah, first test in Southern Hemisphere. Turned out to be, not to be, but at that time, it was a pretty scary time, 2020, and I chaired the CALHN Clinical Ethics Committee at about April. We got that up and running because overseas experience was that there weren't going to be enough ventilators for everybody, and the question was who you would prioritise. The experience from Italy was that anyone over 70 was just put in the corridor and that was it. So pretty scary time, no treatment, no vaccine. So what did COVID do? So COVID did a lot of things to human research and human research ethics. So part of the challenge was the rapidly evolving landscape. So before, ethics committees would ruminate and have extra meetings and send questions back to the researcher. And so what happened during COVID was, hey, actually we need to be a bit quicker than this. And I actually formed a special committee, if you like, a strike team. We had a couple of very, very urgent projects, including the vaccine, had a couple of other things, testing of swabs by dogs because they wanted to pick up people at airports, those sort of studies done at the University of Adelaide. So we actually formed a sort of a strike team and a special committee, and we had people who volunteered from our other committees, and it was a very rapid acting committee, so we could approve things quickly or get questions backwards and forwards. So I think it was the biggest paradigm that most ethics committees around the world had to decide, hey, we need to be a bit of a hurry up here because it was obviously the pandemic. The other thing was scientific merit. So we found that during COVID, maybe that science has slipped a bit, and this goes back to repurposing of drugs. So there are a lot of drugs from SARS-1, 20 years ago, MERS, etc., that had great activity in the test tube. The problem was people were dragging them out for COVID and saying, look, SARS-2, and saying, look, we think these are effective, let's bung them into humans quickly. So there were a bit of a problem because, in fact, there was a big trial in Australia here that was approved in Melbourne, hydroxychloroquine. And the problem was they're using massive doses, 800 milligrams daily. And hydroxychloroquine prolongs the QT interval. And unfortunately, once a patient gets into that problem, that's really hard to fix. And its half-life is about 80 hours. So once it gets into you, it's really hard to manage. So we looked at it here in South Australia and said, under national mutual acceptance, we were obliged to run it, and we said, no, it's too dangerous, we're not going to do it. And then other jurisdictions around Australia started agreeing with us as well, and the whole thing collapsed. But this was purely out of a test tube, in vitro analysis that hydroxychloroquine could kill this thing. And there were a lot of things like that that were dragged out, repurposing for COVID. And you could argue that perhaps some of our scientific analysis and practices slipped a bit during COVID, mainly with the urgency of the pandemic. But that's what happened. So we had to be on guard for that. And so-called expert opinion versus evidence. So this is one of the big dilemmas in medical research, is what's the difference between expert opinion and actual evidence? Dr. X, who's famous, says, I think this, and should everyone go along with that, or say, well, show us the evidence? So that also came in COVID, various things like masks, lockdowns, based on almost no evidence. We haven't been through a pandemic since 1919. So a lot of this stuff had almost no evidence. It was just people's opinion. And to be fair, though, it would be really hard to design a mask trial, for instance. How do you prove that masks works? Often it was done on expert opinion. So there are also ethical thoughts in trial designs. So we did, in England, they did to prove that dexamethasone was great in treating COVID was the adaptive trial designs. You have 3 or 4 arms, and then using Bayesian probability you take out the worst arms, and finally you end up with something. So adaptive trials really got there going during COVID, because adaptive trials had never been used much before, and so now adaptive trials are all the rage. So COVID changed a lot of the paradigms with some of this stuff. And placebo vaccine trials. Vaccine trials have been quite controversial, whether you use a placebo or not. So that was talked about in the ethics space. How do you design a trial? Really, there's nothing else. It has to be against placebo. What are the ethical implications for that? And so vaccines got up pretty quickly in the history of the world. From the time the spike protein was, the structure was analysed in January the 20th, I think the Chinese had determined the structure, to later on in the year, August, September, the vaccines were rolling out. So that's unheard of in human history to do a vaccine that fast. And of course mRNA, which is the other technology. I'll cover that in a minute. So COVID also challenged previous pandemic thinking around, obviously during 1919, people in Adelaide, for instance, were taken to where the exhibition oval, which is behind the University of Adelaide, stuck in tents, and my grandmother, long dead, remembers telling me that there were soldiers with rifles all along North Terrace, so you weren't getting out of there if you had flu, right? And so that was our concept of quarantine. You shifted people out there. Okay, come to COVID, bit difficult to do, can't shift everybody into tents on North Terrace. So the question was, I think public health thinking sort of changed, and okay, we accepted lockdowns initially, but then there was some protests, etc., etc. So I think it changed our views on masks and lockdowns, but now people are sort of over the curve. We're sort of getting over it now. Mask wearing is gone. But initially people were quite enthusiastic, I think, and the lockdowns, I think, was quite enthusiastic, but then obviously it wore off. So yeah, it's changed our thinking on those things. It also challenged informed consent in the ICU setting. So with COVID, often these patients were very, very sick. How do you get consent? Is consent from relatives enough, or next of kin, when these were interventions, right? These weren't just low risk things. This was an actual intervention, do or die. So a lot of questions in the trials about how you went with consent. And especially the sick patients, how could it ever be informed? And the next of kin, obviously, was that satisfactory? So there's a big debate in England particularly. Or waiver of consent. You just say, look, sorry, we're just going to do it, and not worry about it. Not worry about the consent. So consent was a big thing in the ICU settings. And prioritisation of COVID research over other areas. So this was a criticism of COVID seemed to have money coming from everywhere. Even the universities, money pouring in for COVID studies, and people were arguing, well, hang on, we're neglecting other areas of funding that we could use. So COVID research really got a lot of money. And in fact, the vaccine in Queensland got $1 or $2 million and from the government, and then proved it had people tested positive. We're going to test positive to HIV because they inserted a HIV gene in it to get into the cells. Unfortunately, that meant that people were going to test positive for HIV once they had the vaccine. So that was almost a non-starter. However, I think they've taken it back and redeveloped it. So yeah, the funding was money tree. There were criticisms that famous people got more money than non-famous people who might have had better technology. So I think if it happened again, we would probably look at how we prioritise funding for COVID stuff, I think. Because the criticisms, that money was just handed out to various people on what basis. And also the biggest one, probably surge capacity in public health systems. So in April, I formed the CALHN Clinical Ethics Committee, and that was the Who Do We Switch Off committee. So the clinicians down at the RA were saying, wow, what's our legal position? If we put someone in the corridor and we say, sorry, we have to prioritise someone else, what's our legal position if they die, relatives sue, etc., etc. So we looked at all the practices around Australia. There wasn't much. Overseas was pretty horrible. If you remember the scenes from Italy and that, again, it was over 70, you were just put in the corridor. Turned out there weren't enough ventilating machines in the world, and it turns out that Germany is the only place that makes them, and it turns out the United States bought the lot. So we'd had an order in South Australia. We had an order for whatever, 100 machines. and then I got a phone call saying, actually, they're not coming. The US has bought the entire year's supply from that manufacturer. So that's my argument about prioritisation of this stuff over other needs of the health system. So I had all sorts of proposals come to the committee about making ventilators from CPAP machines, reversing the suction to make a ventilator of a CPAP machine. Had one with a Coke bottle. A company in Melbourne, you could do it. You do it in places like Indonesia, where you could build it with a Coke bottle and a CPAP machine. Just incredible stuff. But this was going to be the problem, right? There was a shortage of ventilators in the world, so a pretty scary time. So had that come into South Australia or even Australia, we would have just been overwhelmed. I think there's only 60 machines in South Australia, maybe. I'm not sure, but we would have been totally overwhelmed. So that was one of the big problems, the surge capacity in the public health system. The other thing is that clinicians were becoming infected, right? So what do you do for clinicians if where you don't have a surge capacity? So I think next time we would probably, or now the world needs to sit down and say, well, what do we do for a surge capacity in pandemics? Because we don't have one. You know, we can't, as ramping down there as it is, what we do if 1,000 people turned up at the Royal Adelaide with some new disease. So I think we need to think about that. And that's part of the problem that, okay, everyone's forgotten about COVID now. People say, what's COVID? You know, we're all over it. There'll be another one, as, I don't know what it'll be, but there'll be another one. So what do we do next time? We need to be better prepared than we were this time. So yeah, that's the ethical things that COVID challenged. That's a guy I'll mention later, who was in jail, Hugh Jun Kay. I'll mention him in a minute. So if we go back to 1958, I just want to go back to the future here and talk about hype, reality and ethical issues. So if we were here 65 years ago, the year I was born, very good year. So what was the world? What did the world have in medical technology, right, in the 50s? And trust me, I remember some of this. So vaccines were the big hope in the 50s. And if you talk to your grandparents or people who are in their 80s now, they remember the polio epidemics that we had here in the 40s or 50s. An absolute scourge. Every summer, the pool, where the Festival Theatre is now, the pool would be closed. Theatres would be closed. Horrible. Young people would wake up paralysed. They'd be out at Northfield in an iron lung. Just terrible, right? So I think this is one of the things that COVID brought out, that up until COVID, we hadn't seen disease for 40 years, right? Doctors were struggling to see a case of tetanus, diphtheria, measles. They've gone, right? We've vaccinated them out. TB in Australia was eliminated in the early 70s, right? We'd eliminated these childhood diseases. And so if you're a medico and there was a case of tetanus, I can remember in the early 80s, everyone flocking to see a case at the Women's and Children's. No one had ever seen a case of tetanus, right? So people had lost the fear of disease, right? If you go back to the 40s and 50s, there was polio, there was scarlet fever, all these diseases were scourges, right? Polio especially. And I like to show the anti-vaxxers the graph of polio. I haven't got it here, but in America, polio cases climbing, and then the vaccination, there's a vertical drop the next year, right? Please explain that without vaccination, right? So these diseases, we'd forgotten about the effect of disease on society. So and so our vaccination rates have dropped. But this was the thing, that we'd lost our fear of disease. So when COVID came in, hey, these things, it does come back again. We do have disease and we have to act accordingly. So in 1958, vaccines were the big hope for the world. World Health Organization hoped to eliminate malaria. So the hype was, yep, we can knock off all disease will be gone. So we can knock off malaria, typhoid, cholera, all the childhood diseases, diphtheria, tetanus, blah, blah, blah. So that was the hype. The reality was that some of these diseases were a bit harder to get good vaccines against, right, and still are hard. So we managed to get rid of smallpox. 1968, that was gone. Polio was virtually gone. There are a few bits and pieces around the world, but we can say that's gone, basically. Tetanus, all these diseases basically have 99% gone. The ones that are the stubborn ones are malaria, your dengues, those sort of diseases that there are no good vaccines against. Zika, chikungunya, Nile virus, all those things that the vaccines are not very good against. So they're still circulating in the world. So the reality was that, hey, yep, we've done really well, especially in developing countries, on vaccinating children. And if you look at mortality rates for 5-year-olds going back, 100 years, they've dropped to 1%. So we've done really well in that. Where we're struggling, the reality is now that there are diseases that there is no good vaccine against. Malaria is the classic, maybe mRNA is the big hope for that one. And the ethical issues, of course, there were, along the way, there were bad stories about trials that were done in other countries, raising ethical issues. Vaccines that weren't properly tested in animals. There was the kidney thing in the United States where the vaccine was done in kidneys, and then that was a polio one, early polio. So I think there were the ethical issues have been how do we test vaccines properly so when they roll out, they are effective. So that was vaccines. Hormonal contraceptives, 1958, just coming. Again, the reality, the hype was, hey, no more babies, people don't need to worry about that anymore. But again, the reality is that, yep, all right, for females that was fine. There's been no male hormonal contraceptive ever in the history of the world so far. They've all failed for one reason or another. So the reality is that they've been sort of semi-successful, and some of the ethical issues around that. How do you test them? And certainly in men, the male hormonal contraceptive is yet to be seen, and because some of the arguments are about ethical issues and fertility, do you switch it off forever and that. So that's hormonal contraceptives. Organ transplants, that was a biggie. 1958, we'd done the first kidney transplant, I think, at the QEH in 59, I think, 57, 59. So world's first virtually kidney transplant here in South Australia. Again, the big hope, everybody who's got a faulty heart or a busted liver or whatever will get a transplant. That was the hype, right? The reality struck in the 60s when the heart transplants, the first heart transplant in 1968, I remember that, fantastic. But the reality sunk in. The first reality is, hey, there's not enough donors. B, there's a rejection, right? So the rejection bit we've sort of got over with better drugs than that. But there's still the ethical dilemma of, well, there ain't enough organs to go around. What do we do? And that's coming up with an exciting new technique. And this area is going to be revitalised, and I'm going to predict in 5 or 10 years that xenotransplantation will be really big, and we'll be raising pigs because of CRISPR, and I'll talk about that in a minute. So transplantation, there was a lot of hype around it. Found that the heart transplants, yep, really tricky. Rejection, but the main factor is there's not enough organs to go around. There never will be, right? There never will be enough. If you got organ donor, everyone in Australia said, yep, I'll be an organ donor, you would still not have enough organs to go around. So, especially kidneys with diabetes, we're looking at dialysis and, there's not enough kidneys to go around. So the ethical issues with organ transplants were many and varied. Who gets it? Who gets them? Who gets them? Do we prioritise? A lot of heart transplants, if you're over 50, perhaps you're not going to get one in Australia. The waiting list is too long. Certainly in a developing country, you're not going to get an organ transplant because of the cost. I mean, these things are hundreds of thousands of dollars. So again, inequity. So there are a lot of ethical issues around organ transplants, but it was a big hope in the 50s. Antibiotics, of course, wow, has that revolutionised medicine since World War II. 1950s, everyone said, oh, there'll be no more infection ever again, antibiotics, blah, 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 we'll give everyone penicillin in the water and everybody will be good. And unfortunately, we've again hit the reality that drug resistance, is rampant. We've got bacteria that not killed by anything. There's no money in antibiotics, so no one's really developing them. So it's a vicious cycle. The ethical issues of antibiotics, again, how do we develop them? Because there's no money in them. So no drug company is going to tackle antibiotics, but there's a desperate need. So how do we do that? Maybe WHO or someone needs to do this independently to make sure we have antibiotics. And of course the ethical, yes?
Sorry, just my naivety, but why is there no commercial incentives for
because they're small use,
yeah.
And they're usually based on technology that's cheap. So we haven't developed any really expensive antibiotics that, mRNA or something. It's all pretty cheap. So this is the problem, that the new pipeline for antibiotics is very poor, and most are charitable people putting money into it now, antibiotic pipelines. WHO has organised this. I think Bill Gates is involved in some of these things, like he is in vaccines, because antibiotics is a big area of need. And Australia's been pretty well off in the past, but other countries in the world are approaching there's nothing that'll kill this infection type of thing. However, Our stewardship is a lot better now with antibiotics. We're woken up to the reality and the ethical issues that we should be controlling them more. We should be getting them out of the animal population. We should be restricting them, you know, to only those who need them, so that we cut down, you know, the evolutionary thing that bacteria do all the time. So antibiotics are a big worry around the world, especially for infectious diseases physicians. But they said they were a great hope. Prothesis. So they thought in the 50s, yep, busted knee, hips, we'll stick in prothesis again. The reality is that these things are very costly and they get infected, and some of them don't work properly, and the main reason is expense. So if you're going to go to these, you really have to have a proper medical system. You know, it's an expensive operation to do a hip, blah, blah, blah. So if you're in the developing world, perhaps you won't get a new hip. There are moves to do things around injecting stem cells into the joint, generating cartilage, those sort of alternate things. So that may come with CRISPR. So we'll see that in a minute. Pathology testing, obviously that was a revolution. The reality is that perhaps it's not as good as we thought it was. Certainly ethical issues in around, you know, think of HIV, how you test, who you test, all those sort of things. Chemotherapy, again, the great hope in the 50s is that we'll wipe out cancer with chemotherapy. Yep, everybody will be wiped out with cancer. Again, the reality was that some cancers have still proven to be, there hasn't been much advance in 40 years, you know, lung, pancreatic, that sort of thing, brain. However, cancer of testes now is virtually 100% curable with drugs. So again, chemotherapy was the big hope. The reality is that it doesn't work for some cancers, it's toxic, blah, blah, blah. And the ethical issues, how do you test these things? Who gets this very expensive type of drugs, for instance? So now the cost of, unlike antibiotics, cost of chemotherapy is skyrocketing because of immune modulators and all these very, very expensive drugs. So the question is, people in the third world who might need these drugs are not going to get them because they're too expensive. So that's the ethical dilemma about this. And you can't even do research in these countries because there's no point. Once you do research, that's the end of it. No one will ever see these drugs. So that's been the issue, is the cost. And then pharmaceuticals, which I'll go into in a minute about 3D printing. But again, pharmaceuticals, the hype was that we'd cure everything with drugs. The reality is that not everything can be cured with drugs, and the ethical issues are cost, mainly cost, and who pays for this stuff. We're probably blessed here in Australia that we have a national health system that funds these things, but in other countries it's self-funded, and so that limits the number of drugs that you can actually access. I mean, the United States is a classic example, spends 10% of their GDP on health, yet has some of the worst outcomes in the world for health. So how do you reconcile that? Especially their pharmaceuticals. You know, simvastatin, for instance, it's about $8 here and it's $80 in the United States. You just can't reconcile the costs of these drugs. And it's getting to the stage now where some treatments will be in the millions. People have to fund their own treatment in millions. Maybe genetic studies have to fund their own. So that's the back to the future. So where were we? The great hope. So let's look at where we are now. And I bring you back to in a minute, mRNA technology. So mRNA have been kicking around for a long time, 20 years, and obviously COVID was its piece to resistance. Away we go. So the first vaccine developed using mRNA technology, wildly successful, I'd suggest, wildly. And Pfizer have made a mint out of this. Pfizer-BioNTech made a mint out of this, but wildly successful, I think. The fact that the vaccine was developed in 9 months, tested, approved in 12 months, got out there, vaccinated. How many billion people say to me, oh, Ian, the side effects of this vaccine? I said, well, hang on, how many doses have we done so far? 4 billion or something? Now, name me one pharmaceutical that's had so many doses stuck into people. I can't think of anything. Maybe penicillin, maybe not. Don't think so. So this has been in at least half the planet, this Pfizer mRNA thing. So it's wildly successful. So obviously mRNA has opened up a huge area, particularly vaccines for diseases that we don't have current very good vaccines. The vaccines are not very good. So malaria, Zika virus, Nile fever, all those odd dengue, all those sort of diseases for which the vaccines aren't very good. I mean, malaria's had vaccines. There's been 30 malaria vaccines, I think, in the last 30 years trialled. None of them are any good more than 30%. So mRNA technology may unleash this. So that's one area. Cancer. So you can make proteins inside you to deal with cancer. The list is endless. So mRNA, again, this is a bit of a hype, but the reality may be different. But if we've seen anything like the COVID vaccine, the people were saying, oh, this won't work and blah, blah, blah. This is the reality was it did work. We didn't hype it, it did work, and it worked spectacularly. And it was pretty well, if you look at the percentage, okay, the percentage of side effects, and it's really, really minimal for a vaccine. So that's mRNA. Just to come back to this chap, CRISPR. Oh, there he is, Hugh Jun Kay, the biophysicist, who sent falsified documents from the ethics committee and falsified things that he was allowed to do in his protocol and completely messed things up. Decided to CRISPR edit a couple of children, and unfortunately what he's ended up now is mosaic cells. They're not fully done. So half of the old, half of the new. So who knows what these kids are going to grow up with, but he's responsible for the next, X years. And he went to jail, and but he did falsify documents, because people say, oh, how did this thing ever get approved? And I said, well, we falsified everything. He went outside the protocol, falsified patient information sheets, falsified consent, all that sort of thing. So CRISPR. So, and this ties in with xenotransplants. So go back 15, 20 years, xenotransplants were going to be all the rage, right? Yeah, we'll raise pigs and we'll get their organs because they're about our size and the organs work similarly. Okay, but what happens? Take the pig organ, put it into a human. Not only does the organ grow inside you, but it has viruses from the pig that get into you, zoonoses. And lo and behold, we had the biggest zoonosis ever, which was unless you think of the lab theory, whatever you think of COVID, the zoonosis theory, that viruses do get into humans and then replicate. So xenotransplantation died a bad death about 10 years ago, and nobody went any further. So come COVID, and come CRISPR. So CRISPR, some companies in the US about 18 months ago now, 2 years ago, decided they would CRISPR. So CRISPR is the thing that the bacteria use to chop up viruses, right? Kill viruses. They chop up the DNA, insert other things. So, we can use this technology. So the CRISPR people decided, look, we can CRISPR these pig genes on their organs and take out the growth factor so it won't grow. We can take out their viruses by CRISPR, and we can use about 6 different CRISPR techniques to make the organ much better. So when we transplant it to humans, it's going to do the job we want. So they lined up this guy in New York. He was a criminal, and he murdered someone, I don't know, bad history. He said, look, I want to atone for my sins. He had end-stage heart failure, no treatment, he was going to die. They said, look, can we put this pig heart into you? We know you're going to die. He said, yeah, I'll atone for my sins, bring it on. So they put the heart into him, transplanted the heart, needed a bit of external help to keep it beating, but the thing went for 1 or 2 months. He didn't die of the pig heart, he died of something, infection or something. But it proved that the CRISPRed pig heart didn't grow, worked perfectly. Whoa, here we are. So at the moment there's 5 or 6 companies in the US alone ready to do human trials with CRISPRed pig organs. So the ethicists get up and jump up and down and say, but you're raising animals for the purpose of human organs. And I say, well, do you eat meat? Yes. Do we kill animals for the purpose of eating meat? Yes. Is that a bad thing? I mean, vegetarians may say it's a bad thing, but most people are quite happy to have animals killed for the purpose of food. So why can't we raise them for the purpose of harvesting organs? I don't know, ethical dilemma. But I think that these xenotransplants now are going to take off in the next 5 or 10 years. You'll find that livers, kidneys, lungs, hearts will be CRISPRed to go into humans. Now, obviously, you've got to fix the problem that the pig heart needed some assistance in this poor chap, but I'm sure that's doable. So watch this space for the next 10 years. So CRISPR is a very exciting technology. In fact, we have a first trial in Australia proposed where piece of mRNA will go and get into the liver, CRISPR a gene and knock it out. So we've had trials here where genes have been added. So we've had knees, a gene goes in to make the the cells that produce the cartilage. That's just, you know, quite a few adding in gene trials, but nothing where it's trying to kill a gene to do something. So it's quite interesting. But if this one takes off, I think this will be a whole raft of things where we can genetically engineer somebody. So if you think of the potential to change a person's genes or knock out a bad gene and insert others, what could we do, say, cystic fibrosis? We could cure that potentially. And a lot of other stuff we could maybe do in embryos. We could CRISPR genes and produce a perfectly healthy baby instead of a baby with a genetic defect. So the potential here is huge. Ethicists, of course, will have a field day with this because, you know, do we modify human beings? I mean, I would have liked to have been taller. Can I CRISPR myself to be 6'3"? You know, hey, you know, I want my kids to be 7'3" and play basketball. Can you CRISPR a couple of genes there? The growth, you know, turn on the growth hormone. So obviously there are going to be ethical dilemmas, and like anything, there'll be the excesses. And this is the problem with medical technology. There's always the excesses first. So we've seen Mr. Hugh and Jay, or whatever his name is, the excesses are out there first. And unfortunately that dampens the technology for everybody else. And then we have to come along and clean it up. The ethicists have to come along and clean it up. So that's CRISPR, again, very exciting. 3D drug printing, well, that's already happening. That could revolutionise pharmaceuticals and drop the cost, which is important. That's what I said, the cost of pharmaceuticals is skyrocketing because they're no longer simple molecules, they're monoclonal antibodies and proteins and God knows what. So if you could 3D print them, that would be, and lower the cost. And the analogy I give is that 40 years ago to do a DNA base might have cost $10,000 per base pair or something. Now it's down to 1 cent or, you know, 100 for a cent. So the cost comes down as you get this technology. So that's exciting. Number 4, and this is where Mr. Tesla is involved, brain-computer interfaces, bionics. Now again, this is, people laugh at this stuff and say, oh, it'll never happen. Well, Elon Musk is already doing it, already funding it. So we've seen a bit with Parkinson's where you can insert electrodes to dampen the Parkinson's, but there may be other things you could do with paraplegia, quadriplegia. You could insert electrodes, they could drive computers, drive your wheelchair, do your speech, all sorts of things, right? Even drive your legs. Maybe you could insert electrode into the spine, which would then power your legs. So this is really exciting stuff. It's and maybe making materials mesh with human flesh, right? The true bionic. So this is a revolution. And people say, oh, it never happened. Well, it's already happening in the US, already happening. That's very exciting. Could offer hope to paraplegics and quadriplegics for maybe semi-normal function. Who knows? Already they've done a trial, yeah.
Like, how would you regulate when it starts shifting from therapeutic use to like potential wider society use of?
Sure.
Like, what are the ethics?
And yeah, and you'd have to do some research and say, well, look, what are the side effects of this stuff? It's all very well to do it, but what are the downsides? Can someone hack into your bionic and then move, you know? So that's a worry. I mean, that's been a worry with cardiac devices. Can someone hack into your pacemaker and then kill you? So, you know, all this stuff needs to be looked at and obviously approved as devices are approved, you know, the proper regulations. So it's not going to happen tomorrow, but 5 or 10 years it might happen. There's a lot of ethical dilemmas with that. I mean, again, this technology would cost a fortune. Again, who gets it? Someone in the third world can get this technology? Probably not. So again, lots of ethical dilemmas. I've talked about xenotransplants. Next 5 or 10 years with CRISPR and other technologies, that's going to be really big. AI, well, there you go. Again, bit of hype at the moment. AI is going to solve every problem. The reality is probably it won't. But the ethical dilemmas are around privacy of information. We've already seen hacking around where people stealing other people's personal information. So how do we prevent that? Probably everybody is out there now. It's going to happen, but how do you prevent that? And someone doing malicious things with your medical information. I mean, that could be things. So AI, but that could revolutionise, again, medical treatment. It's already being used. People say, oh, rubbish. Already being used in imaging analysis. So you can put a computer against an experienced radiologist and there's not much between them. Some radiologists are happy to use it as a tool. Right? Hey, I'm happy to do that, and I'll just check it. So, you know, AI could revolutionise. You know, instead of a radiologist having 10,000 scans to look through, computer does it and just identifies the one for further checking. So, could revolutionise things like scanning. Stem cell treatments. Again, the hype is go back 5 or 10 years, they were hyped. We're going to cure paraplegia. We're going to cure MS. We're going to buy stem cell transplants. I think the reality is that actually there's lots of stuff we don't understand about stem cell transplants. But now you can go to places in Europe where you can get your MS fixed and your injection into your spine for your paraplegia. What they haven't told you is the cancers that have been generated by stem cell transplants. There's been some cancers. So obviously these things haven't been subjected to proper research analysis, right? No clinical trial. This is one of the problems with this new technology. Escaping proper trials and proper regulation could damage it forever. As I said, the dirty word, CRISPR has been a dirty word for a while. Now it's coming back where more ethical and rigorous people are doing it, right? But you'll get this people always damaging the technology when they come in. So stem cell treatments could, again, revolutionise things. You may put orthopaedic surgeons out of business, for instance, if you could regenerate cartilage. Who knows? Instead of a prosthesis, just regenerate the cartilage. Last one, anti-aging treatments. So more cosmetic, but again, the ethics around it. Again, stem cell treatments, the ethics around it are cost. You know, again, that's not going to be in the third world anytime soon. Stem cell treatments will be a huge cost. So again, that's the ethical dilemma. Anti-aging treatments, so everyone wants to not die, be younger. So again, the hype was, and you probably remember body freezing, where you could freeze yourself or your head and wake up in 200 years and fix your disease. I think the reality is that actually we don't know what happens when you cool people down. You can even now they're taking the blood out and replacing it with an antifreeze. And there's one started up in Victoria, I think, where you can put your head down, you know, for 100 years and see what happens and then wake up. But I'm not sure may not be waking up. That's the problem. Can you rescue someone in 100 years? So anti-aging treatments, again, a lot of them have no scientific evidence around them. Yes?
Sorry, just on that.
Yeah.
Is that essentially like a form of voluntary assisted dying?
Yeah, well...
ethically?
Yes. And in fact, voluntary assisted dying has come up about transplants. Sure. So can a person who wants to undergo a voluntary assisted dying, can they give a transplant, you know, have the organs transplanted? Some of them are quite happy to do that. That's been a really ethical dilemma, because when do you die? There's rules around transplant when you can take the organ, and voluntary assisted dying doesn't fall into that. So they're thinking of changing the law that maybe you can, if you're voluntary assisted dying, yep, I'll offer my organs for transplant. Now, obviously some people's organs are not in the condition to be transplanted, but that's producing an ethical dilemma. So back to what we were talking about before. Anti-aging. Oh yes, the freezing. What was your question? Sorry, I forgot.
I'm just interested, because if we don't know exactly what's happening with these bodies, how does the company ethically put something?
Absolutely, and this is the problem, that you sign a waiver to say, well, if I don't wake up, it's none of their business.
And private enterprise can just...
Yeah. You would have to say that if you take out someone's blood and then put antifreeze in there and then freeze them, the possibility of them being thawed out, I mean, how would you even thaw them out? I don't understand that, because surely all the cells would be damaged. And how do you restart their heart and give, you know, I just don't understand how that would work. But maybe in 100 years there'll be technology to do that. So, yeah. But a lot of these anti-aging treatments have not been subjected to rigorous research. And of course the ethics around them is wild. I mean, you just raised an ethic. And then, you know, again, it's all cost. You can have anything done because it's cost, you know, and of course the government's not going to pay for any of this stuff. This is the problem. So how do you know, you can imagine what stem cell treatment for some of these instead of a prosthesis would cost. So they're the ethical dilemmas for what we face, I think. But like everything, there are sort of idiots that play with the technology and ruin it for everybody else, and that's happened with other technologies. But eventually it settles down and the regulation comes in, and unfortunately often practice travels a long way ahead of regulation. So something will happen and then the government says, oh my God, we have to regulate this. I mean, stem cells are classic. That was going on here in Adelaide for years until TGA stepped in and said, actually, are you using GLP? All right, it's auto, you know, it's the same patient using the same cells, but you're using GLP, a good laboratory practice, you know, otherwise you're inducing infection, blah, blah, blah. So they tightened the rules around that. Even like fecal transplants, for instance. So fecal transplants have been around for a long time, and the idea had been you pull the feces and make a big mash, and then you put it in, right? So TGA came down and said, no, you can only have individual donors now, and you must assay them perfectly and make sure everything's fine. So that's sort of almost like a blood bank where you've got to have individual donations. So what happens is people do stuff, and then regulation comes in to say, actually, no, that I want you to do it this way. I mean, not that pooling of donations for fecal transplantation was unsafe, but the TGA viewed that, look, actually, we better put some regulation around just in case. So that's the problem. Regulation is often a long way behind current practice. So these technologies will be waiting to be seen, but I'm sure there'll be lots of ethical dilemmas between now and the next 30 years. But it's probably the best time to be alive in human history, I think. For the person born now will live to 100, 130 or whatever, I think. 60, 70 is the new 40, as they say. I hope. But we're all living, thanks to medical science, we're all living healthier lives and longer lives. As I said, the problem ethically is to get the rest of the world up to our standard. Third world, there's still issues, a lot of issues in the third world. And that's where it's exciting that mRNA could crack malaria. Malaria has been a scourge in the third world for the last 500 years. And 1 million children, I think, still die, 500,000 children still die of malaria each year. Even places like Papua New Guinea, Africa, it's all drug resistant now, hopeless. So, maybe mRNA vaccines will crack it and we can kill malaria forever. So that'd be rather exciting to kill a disease, I think. So yes, that's it. Any questions?
And throughout all of this, how do you, first, thank you for all of this.
That's all right.